Hi, everybody. Thank you again for the invitation. Anne is just a force of nature. I think we all kind of know that. We don't understand how she does what she does, but we are very happy to be in your orbit. And thank you very much for the invite and for putting all of this together. I see some familiar faces in the room. Hello, everybody. These are my disclosures, which have nothing to do with what I'm talking about today. So what I'm talking about today is progression of disease. And in this scenario, unfortunately, progress doesn't mean getting better. And this actually, it's quite confusing to people sometimes to say, well, progression of disease, is that a good thing? Not actually. So what I, unfortunately, am typically given to discuss, thanks, Anne, is the disease getting worse, but afterwards, so I'll talk quickly, and then I believe we have a group massage or something to help you recover from everything that I'm going to say. So here goes. So what actually are we talking about when we say progression? And I think that when anybody is diagnosed with anything, there are quick questions. How do I get rid of it? And is it going to get worse? But what exactly does worse mean? What is worse? How much worse? When is it going to get worse? Is there anything that I can do to stop it from getting worse? And I think that when you're talking about diseases like myeloproliferative neoplasms, which have sometimes decades, we hope lots of decades in a lot of patients, what does that mean? Am I fine for 30 years? Am I getting progressively worse in a sort of linear fashion? I think these are questions that patients really struggle with, and I'm going to walk you through some of the ways that we try to tease this out in clinic, but I'm going to repeat myself several times by saying that fortune telling is much better served a few blocks down on 42nd Street. They have nice tables with little jingly things, and they've got cards. And I would have a lot more confidence in many of them than in us with respect to fortune telling. And I'm going to repeat this very specifically as we go through some of the prognostic scoring systems, because one thing is that, patients should not be ever treated as a loaf of bread, right? There is no expiration date that should be stamped on, and my hazard always in discussing progression is the worrisome outcome of people getting fixated on time points and of dates. I think that's a huge error, and I'm going to try to stay away from it. So here's a fun slide. So one thing that I think it's important for people to think about is that there are actually treatment guidelines that are used pretty much for anything you have. If you have a foot pain or back pain or cardiovascular disease, there are actually guidelines to try to figure out what is it that you have and what are the medications or treatments that are typically recommended. So these are NCCN guidelines. You can look these up online if you want to give yourself a headache. They're National Comprehensive Cancer Network guidelines. And the first thing is, what are we actually talking about today? So what you can see possibly on this slide, I think it's big enough. So this is divided into myelofibrosis, polycythemia, and essential thrombocythemia. So let's just stop right there. Does that work for everybody in the room? Is there anybody in this room who has MPN/NOS? Probably. It shows up half the time not otherwise specified, or you might have a JAK2 positive myeloproliferative neoplasm, or you might have a myeloproliferative disorder, or you might have a myeloproliferative syndrome. There's a lot of nomenclature actually that is quite challenging to sort out, and patients find it especially confusing nowadays when you get your own chart and you see your notes and sometimes even the billing sheets that, well, wait a minute, that guy who just saw me over there says that I have ET, but you just said I have a JAK2 positive myeloproliferative neoplasm, and the other person said that I have some myeloid disease. It's actually a bit confusing, and it's worth it to spend a little time to try to figure out which box do you fall closest into? Because there's a big Venn diagram between these diseases, and sometimes it's not exactly sure which one of these arrows to follow. But what you're going to see if you follow out the arrow is an immediate attempt to stratify patients with respect to risk. Now, risk for what? Risk for progression, risk for development of complications. For example, here I'm going to talk very specifically about the models for myelofibrosis in a minute, but you can see right out of the gate, there are many of them with a lot of letters. There's MIPS, there's DIPS, there's IPSS. You can see immediately, I think for polycythemia vera and for ET, that there is a stratification into lower and higher risk diseases. These are based on what mutation you have. These are based on your age. And I think it's important to try right at the outset of getting organized into where might I fit on any kind of classification system. If they think that my disease is mostly behaving like PV, how old am I? Have I had a blood clot? Do I have a JAK2? Presumably you do if you are being called PV. Now things get worse, though, because if you look here at the models of myelofibrosis, and I don't think I can point, so I'm actually going to keep turning back and forth to try to show you what I'm talking about. So there are columns here. You can see IPSS, DIPSS, DIPSS+. Couple of basic points of prognostic and risk storing systems, and this is the absolutely most important one, and I talk about this with the fellows all the time. These systems are dependent on the available treatments. Let me just repeat that 23 times. When you come up with a risk assessment of how likely is somebody to have overall survival with this, that, and the other risks, that is in the context of available therapies. If you look, for example, at acute myeloid leukemia, AML is a disease with very, very challenging outcomes. It's a serious disease where previously, if you looked at prognostic classification systems from several years ago, you would see, for example, that patients with a mutation called FLT3 had actually awful outcomes. And now they don't, because we have FLT3 inhibitors. So there is a constant scramble to update the classifications based on the available therapies. You might have noticed that in the myeloproliferative neoplasms, we haven't exactly been dripping in fabulous treatments. We would like more of them. It's better. We have better treatments. We have better JAK2 inhibitors. We have a lot more research in this space in the last 10 years than in the 30 before. But we still don't have the blockbusters that take people out of certain categories and put them into their own category. And you've got to watch this space. If you look over here, what you're going to see in the progression from left to right as we got to the DIPSS+, there are a bunch of things in there. Your age is in there. Whether or not you're transfusion dependent, the earlier classification's not there, the later one, the DIPS+, it's there. Cytogenetics. Who knows what their cytogenetics are? Did you even have a cytogenetics test done? Take a look and try to see for yourself, do you have the data that would allow yourself to be put into one of these? And actually, there is a very horrifying article that says that many, many experts in the field will actually give the patient all of the current prognostic scoring system results, which, guess what, are not always the same. So you might have in the same visit an IPSS, a DIPS plus, and a MIPS, which are all slightly different, which is super fun when that happens. But the reason that that happens is because you don't necessarily have all of the data to risk stratify yourself at a particular visit. And this is important. Do I have cytogenetics? How do I get them? Did the doctor check? If you look on here, what we're looking for across all of the MPNs, how old are you? What is your white count? What is your hemoglobin? Are you transfusion dependent? And increasingly, what is your mutational profile? What do you have that might fall into the category of high-risk mutations? Because that gets us then into what we call the MIP 70. This is most everybody now has actually next-generation sequencing data available in the United States. This is absolutely not true out of the country, and even within the United States, it's patchy geographically how on board people are with the testing. But there are a series here of high-risk mutations, and it's an alphabet soup. You may have heard about some of them. There's ASXL1, EZH, SRSF2. There are different categories of mutations here, which are beyond the scope of the discussion right now. But what you need to know is that if you have the level of leukocytosis, the level of anemia, what your mutational profile is, whether or not you have abnormal cytogenetics, these are what we use to see how twitchy are we on your behalf that this disease is going to result in progressive bone marrow failure on the sooner side, to the point that we might even be wanting to think about allogeneic stem cell transplant, which remains the only curative option that we have, versus do we think we're okay to sit still? I have many patients who don't read the book on any of these, and I'm going to talk about specifically why certain of these criteria we take with a grain of salt. But if you look over here, and I know this is high risk because you're all going to take a picture of this, and you're going to go home and you're going to do this, and then my email is going to blow up. So don't do that. But I did put a website on here where you can get a sense of what is it like to dump all of your data in and get potentially 4 different risk prognostic scoring systems. Do not do this unassisted without wine or something. But you're going to see here, the point is, what are we looking at? And this includes a lot of information. If you look up here, you're going to see things like constitutional symptoms. What does that mean? It doesn't mean that your apartment's hot and you were sweating. Drenching night sweats, serious fatigue, fevers, Karnofsky performance status score. What can you do? Can you get up and do your activities? Can you not? Are there blast cells? What is your platelet count? There's a lot of information here clinically that we're trying to put together a picture for you of, do we think you're quiet? Is this disease going to hang out, or is this disease on the move? And I do think it's extremely important to take a look at the molecular risk stratification, because that is what is changing the world right now in terms of biologically understanding what is happening and how fast is it happening with the disease. And I have a picture of that. Now, these have been for primary myelofibrosis. As some of you in the room know, you can start out with a diagnosis of myelofibrosis, but you can also have ET or PV as your initial diagnosis, which may progressively turn into myelofibrosis. The disease of myelofibrosis is not the same as having a bone marrow biopsy that comes back with a little bit of fibrosis. There is reticulin fibrosis, there is collagen fibrosis. It is completely annoying, actually. Sometimes in pathology, they'll put up a slide and say 2+ fibrosis. The rest of us are kind of going like this, like, is it my contact lens? There's some like brown stuff. It actually looks a bit like this. When you see the staining of the fibrosis and somebody says 2+, and we're looking at each other going, do you know how to do that? There is a lot of lack of specificity sometimes, which makes it very upsetting for patients to sometimes look at their marrow reports, because you might look at one from 5 years ago where nobody mentioned anything about fibrosis, and perhaps there's a new one that talks about fibrosis. Is this disease getting worse? Well, it might be. And here what you have is a separate, called MySeq, a separate prognostic stratification system or risk assessment for patients who started out with ET or polycythemia vera and are developing fibrosis. Well, how does that work? Is it just the smeary stuff on the slides? If there are pathologists in the room, this is for you. But is it more? Are there blasts? Do you or do you not have a CALR mutation? We try to be concrete, and then we look in clinic and look in our experience and look at what we think is actually going on with the patient. When you look here at some of the survival curves, and I do not put a lot of survival curves in talks like this because I actually don't think they're that helpful. They put everybody in a bad mood. They're very, very, very tough to analyze, but the reason I put it here is because of the terminology. Low intermediate 1, intermediate 2, and high. The only thing that is understandable to anyone is that if I'm low risk, I'm definitely living forever, right? That's what the clinic visit. And if I'm high risk, what are you going to do about it? What is intermediate 1? What does that mean? What it means, unfortunately, when you're looking at these curves, is that actually they do slope down. So these are the diseases that can become life-threatening, that do become life-threatening, and the question is when, how long is it going to take, and how can we interrupt it? I do think when you look at these, one of the important things is also to look at the ranges with them, because when you are contemplating something like a stem cell transplant, which is what is always kind of in the room as, should I be doing that? Should I get a transplant and just cure this, and then I don't have to go to these meetings? We would all do that if there wouldn't be extensive risks associated with transplant. We would all just say, get rid of it, get them out of my office, cure it, solve the problem. But the problem is that stem cell transplant is risky, and there is an upfront risk, a 30-day risk, a 100-day risk. If I'm looking at curves that have me living for lots of years, what would be the reason that I would be taking a 30-day or a 100-day upfront risk, right? That's why these curves are a little bit helpful, because you are much more willing to take an upfront risk if there is a poor chance that 1 to 2 years later you're going to be okay, versus many years later. If you think you have a very good chance of being okay for many years, maybe some of the research that we're doing right now will preclude ever needing a stem cell transplant. And actually, I can tell you that is happening in the acute leukemia space, that there are patients who even just a few years ago we definitely would have sent for a stem cell transplant that now we aren't. So there is progress, and it is a procedure that's not so much fun. If it can be avoided, you should. Now, this is a doozy, but what I want to show you is, if you can see going from left to right, what this is trying to show is exactly the term that I'm calling progression. What is happening along the way to make things worse? And what this slide shows is a couple of important things. First of all, the acquisition of badness is the acquisition of mutational abnormalities that result in picking up the pace and driving the development of angry leukemic clones, which then along the bottom, the red line along the bottom, normal hematopoiesis to ineffective hematopoiesis. So you're doing well making blood, making platelets, making white cells. You're getting wacky now. As you are acquiring different abnormalities, the counts are all over the place. I have people who will have a white count of 30,000, but the platelet count is 87,000. The bone marrow becomes dysregulated. It's no longer tightly controlled in making the number of cells that you need. That's ineffective hematopoiesis. And then at the bottom, this concept of chronic phase to accelerated or blast phase. And I'll talk specifically in a moment about the definition. But the point here is the acquisition of actually increasing ineffective, bad leukemic stem cell populations in the marrow, which erode normal blood cell production and which result in this sort of, you can see anything that is clonal. Clones are always bad. We talk about clones, it's like Star Trek or Star Wars, stormtroopers. Anything that looks the same are the bad guys. You don't want to have an accumulation of bad leukemia cells. Those are called blast cells. As those start getting higher in number, the normal function of the bone marrow starts declining, and this generally coincides with the acquisition of additional mutational abnormalities, suggesting this genomic instability, or, and I'm not even a Star Wars fan, but it just works, disturbance in the force, right? There's something wrong. You're getting more and more abnormal mutations. Often patients will, in fact, come in and have 3 or 4 different ones, or they might pick up a mutation in something, for example, called IDH, isocitrate dehydrogenase mutations. IDH1 and 2 are kind of, those are more associated with acute leukemia. Is this marrow trying to go in the wrong direction? So definitions and timing, now that the scary slide is over, how do you get there and what does this mean? Okay, this is really important. There is a definition on a piece of paper that accelerated phase is from 10 to 19% blasts either in the peripheral blood or the bone marrow, and blast phase disease, or the acute leukemic phase, is greater than or equal to 20%. This is a huge headache. I can tell you I have been involved recently in an incredibly interesting meeting. I can't tell too many specifics, but leave it to say, several real experts, you would, plus me, in a room talking about cases with data in front, defining whether the patient has accelerated or blast phase. How easy is this? I mean, your kids could do this, right? Count the blast, where's the report, accelerated blast phase. That's what the protocols will say, that's what the report says. Let me just tell you, it was approximately the same type of experience as giving the same set of facts to two different political parties and literally hearing 180-degree difference on the what you think is the same set of information. We actually weren't able to agree. This is incredibly important to you guys in the room, because if you have a blast count of 18%, you can go, oh my God, last month I didn't have this, now I'm in accelerated phase. There are lots of caveats. Did you have a urinary tract infection? Do you have a cold? Was this a manual differential? Was the person reading the manual differential hired the day before yesterday? This happens, and all of a sudden, the next day you look at your labs, boom, all the blasts are gone. We had this happen, in fact, recently, that there was a particular day in the office at a major center where we actually do know what we're doing, that we were all calling the lab and saying, nope, something's wrong, not believing this, and every single one of the blast counts that I didn't believe, poof, gone. There was a glitch. So you do have to know that something that is as incredibly important as this topic is very important. Progression of disease, worsening of disease, everybody is scanning their numbers. And yet what I'm doing is introducing doubt about the blast percentages that might show up on your report. The other thing is that's very important to consider is that we do not view this as a line in the sand. Even if I'm calling somebody accelerated or blast phase disease, there are lots of different clinical circumstances that govern what we are actually going to recommend for the patient. There are patients who are referred to me on a weekly basis, acute leukemia, 20% acute leukemia, out, go and see me, I'm the leukemia doctor. I may or may not treat you for acute leukemia. So the clinical opportunity or the clinical decision-making that we do with a patient isn't actually driven exclusively by this number, and I cannot emphasize that enough, because there are actually patients in all of our practices who might have literally 22% blasts who are hanging around for years, and I'm staring at it, and it's not because I forgot. And there are other patients who really, really do need to be admitted quickly, and we better try to do something because the disease has taken on a very rapid course. So it's not all about the numbers, these are the definitions. The second part of this slide that is quite important to look at is that most of the time when patients are given this diagnosis, it's unusual to actually know what this diagnosis means, but it's very common that people know that acute leukemia is bad and they don't want it, and they go online and say, oh my God, this turns into acute leukemia, I'm dead. So if you look at the transformation rates, again, with the caveats that I told you that even the definition of transformation can vary from expert to expert, it's not that concrete. You can see that for myelofibrosis, they are the highest for PV and then for ET lower, but even these are far from 100% numbers, in fact, much smaller. And patients usually are pleasantly surprised because they assume that there is actually an inexorable progression to acute leukemia and that it will definitely happen at some point. It is actually not the case at all. Most patients don't eventually transform. The reason we discuss transformation to acute leukemia a lot is because our therapies for that aren't good. There's no particularly nice way to state that. We do try, we have things that we try, but the treatment of true acute leukemia that emerges after myeloproliferative diseases is challenging and difficult, and we would love to not have to get there. At the moment, we don't know how to specifically prevent that. So patients will invariably say, well, what can I do? I read about what happens when this gets worse. What can I do to prevent it? Working on it. There are lots of things that happen that are much more common in myeloproliferative diseases than acute leukemia. And some of those are heralded by these types of signs and symptoms, some of them. People will say, is it possible that I'm just going to flip from one day to the next and turn into this? It's pretty uncommon. I can never say never, but it's uncommon. Usually, some of this stuff is going to be what's going on. So constitutional symptoms are reasonably common with things like fatigue. Most MPN patients are very well versed in fatigue. It's a very, very prominent symptom with MPNs. This is different level of fatigue. You guys know yourselves, you know what you can do, different level fatigue that cannot be explained by bad things happening that week or a tough week at work. Generalized weakness, weight loss can be dramatic, actually. The sarcopenia or loss of muscle mass can be dramatic, that you're saying, I'm going to the gym, I'm doing what I used to be doing, but I can't hang on to weight, I can't hang on to the muscle. Increased splenomegaly can happen, but doesn't always. Sometimes it's a prominent feature, and sometimes you can get what we call a spleen attack or a splenic infarct, that all of a sudden there is pain on the side because the spleen has gotten bigger. That can happen, doesn't always. Worsening blood counts can be all over the place, way up, way down. Polycythemic patients will often say, can I get back some of that blood that I've been giving for the last 20 years? You know, what is the refund policy on that? Because they've been phlebotomized for all of these years and then become anemic. So blood count abnormalities are common. And then just to touch on this, this is not a treatment talk, but of course, what are you going to do? What are you going to do? So when you start reading data, progression-free survival is actually an outcome. So everybody talks about overall survival. We understand what that means. But progression-free survival matters a lot to patients. How long am I going to live before this stuff gets worse? And what types of medications might help me there? So ruxolitinib, so all of the JAK2 inhibitors are in this category of hopefully making progression-free survival better, but some of you have been reading about the MAGIC PV trial, which has just been out. It's getting a bunch of buzz. So the question is that, are we actually sort of entering a phase of trying to understand how, for example, ruxolitinib or other JAK2 inhibitors could be used to drop JAK2 allele burden, to improve progression-free survival, not only to treat things on the other side. These were in hydrea-intolerant patients. There's a lot to unpack in these data that don't make it simple enough to say, just take that for everybody. But the goal is always to take our good therapies and move them earlier. Can we move JAK2 inhibitors earlier, and can we prevent complications? Interferon, lots of discussions of interferon. I grew up in the home of interferon. It was actually Dick Silver, who is in his 90s and very happy about the absolutely yearly emerging data supporting the use of interferon. We have an approved agent for polycythemia. We have available interferon for many patients to damp down inflammation in the marrow. And many of us in the field believe that there is a benefit in protection against myelofibrosis, or at least slowing it down. Allotransplant is the elephant in the room always, that should we do that? When should we do that? That is obviously a topic for itself. And then the bottom is the cool stuff that we all want, because we don't want the transplant. Could I get a vaccine? Could I get a CALR vaccine? You may have seen some of the emerging data, not there yet, but incredibly interesting. Are there monoclonal antibodies? These are easier to take than chemotherapy. What could we do early with anti-inflammatory medications? Ellen already talked about canakinumab, for example. There's a whole world of study of damping down inflammation. How could that help? This is not 12th of never data. We expect that these things are going to be becoming relevant soon. So what I tell patients who are not in shape for a stem cell transplant is that not to despair, actually. Maybe they are being saved from a transplant because something better is coming along. So I think the outlook is very optimistic. I would also, as Ellen did, like to thank my colleagues at Cornell. It actually does look like that at night, and we are always there late at night, and it's very nice to see all of you, and we should move as quickly as possible to the de-stress portion of the meeting. Sorry for any stress that I have caused.